And so, oh, who had a question here for me? I had somebody in the chat with their hand up. Okay. And so,
yeah, it's me.
yes, question.
Yeah, please, I just want to know if you are in school, and if you are in school, can I know which room you are?
I'm in the simulation lab. Because remember, people, if they were going to come face to face, they were going to let me know. Otherwise, we were going to tape record this so people didn't have to come to campus.
Okay, so you are not in school now.
Yes, I am on campus. I didn't go to the classroom because nobody indicated they were going to be here. So I'm in my simulation lab right now.
Okay. Okay, I have someone that would like to join you. Is it okay for the student to come, or she can join online as well?
Who would like to join?
One of my one of the students. She came to school and she went to the class and she couldn't find you. Then she asked me to ask if you are in the class.
No, I'm not in the class because I asked if anybody wanted to come to class. I got no response. So I'm in the simulation lab, broadcasting from campus here, the simulation lab. But I provided the links. Has she not received the links?
I'm not sure. Probably, maybe she doesn't have a network or something to join you. But I'm gonna let her know that she should find internet to join you online.
That would be preferable. Just join me online, and she can just join me on her phone, just like you.
Okay. Okay.
But
thank you.
No distracted driving. Yeah,
I know.
This was made for ease of everybody because today is the busiest travel day and people are not able to get to campus, and so that's why I opted to do it this way.
I know. Yeah.
Class on Monday. It's just to make it easier for everybody.
Okay. Thank you. I'm gonna let her know.
Okay, that's great.
Thank you
so much.
Thank you.
Okay,
yeah,
don't forget to mute yourself now.
Sure.
Okay. So now I'm gonna go. Now I'm gonna go back to my share screen. Okay, and so I'm going to pick it up here. For those of you who I might not have had it on record for the first couple of slides, I'm going to add those on to the end for you. But for those of you, for the rest of the group, we're going to pick it up here at discussion. And so what does diversity really mean to you? And please, feel free to pause and just sort of reflect on that. What does diversity mean? What makes people similar and different from each other? And how is diversity different from culture? So just sort of take a moment, put me on pause, and think about that. And so what does diversity mean? And it really just, the definition is difference. And so to me, when I reflected upon that, I thought people are all very similar in that they have basic needs. We talk about Maslow's hierarchy of needs. We all have different wants and desires. And so what makes people different? Well, it's their culture, it is their life experiences, their family, society values. And so that's how we create these differences. And I just want to identify that diversity does not mean just culture. And I have a sense that people just sort of fall into that mindset that it is just different cultures, and that's not it at all. There is lots of different diversity, gender, all different types of examples of diversity. So human culture is defined as a learned behavior that's acquired by individuals as members of a social group. So every society has norms that will govern that society. And so that's how that piece becomes encultured to that society. And that is an example would be how we are at our school are enculturing the RPN to BSc in practice. So we're immersing you in that culture. We're giving you strategies. We're sharing the expectations, society's expectations of RN practice with you over the course of the next several years. Customs are those learned behaviors that are shared and practiced by members who belong to a certain group. And culture and diversity are also influenced by opinions, although I kind of cringe when I hear opinions, but that is the definition. Opinions, knowledge, and faith is the acceptance of truth or reality, that something is, that's the way it is with or without proof. And so a lot of times, one of the examples that comes to mind is that, chicken soup, or, if you're a particular culture that believes that chicken soup will avail you of any of those, of colds, or you'll get rid of your flu if you have some chicken soup. And there's no scientific evidence, although I have to say I think there is some small scientific evidence starting to emerge, and that really is all about, I think, fluid intake. But again, these are the things that these have been passed down for generation after generation after generation. And so those are those beliefs based on opinions. Well, I gave the chicken noodle soup to my son and he got better, so I better make some chicken noodle soup for you. And so that's how that belief and opinion sort of works. And again, just some definitional terms around diversity, so that notion of being different from one another, culture, the beliefs and social practices and characteristics of a racial, religious, or social group, ethnicity, and again, I don't want to fall into, even with cultural or ethnicity, we know that certain people do not practice the entire philosophy to the letter, and some people are practice it, are very overzealous and practice it. So there's a wide variation when you are coming to culture and ethnicity. So with culture we can't just assume race, the biological piece, that race refers to a population that's different from other populations, and a minority is a group having little representation or power, or quite marginalized in that society. So culture and ethnicity are important considerations for student learning, but diversity includes many other individual characteristics as well. So getting back to that, what is diversity? And it's the quality of being composed of many different elements. It's a point of respect in which things differ. Variety. Diversity is variety. But I think that as we value diversity, and we're very much from one of those, a just culture that does value diversity, and I think of some of those other cultures that marginalize different genders or different practices, and how they're really ostracized. And so really valuing diversity is when you really, it's okay to be different, but it's to know what your values are and to know what their values are, and to be respectful. So in recognizing and responding to diversity, this is what they refer to as a wheel. It sort of gives you some of those core underpinnings that oftentimes when we look at diversity, it's age, physical abilities, or physical qualities, ethnicity, gender, race, and sexual orientation. Those are the common, but really there's others, and you can see around the wheel that there's many other types of diversity and things that influence diversity. So responding to diversity is a lifelong process. So once you develop cultural humility, doesn't mean, okay, I got that, check, moving on. It's something that you have to practice all the time. Different people will have different starting points. Differing experiences will impact on the development of particular areas. And so being aware involves examining oneself and exposing one's prejudice and biases. So having that cultural humility starts with that awareness. And so being aware and examining one's own beliefs, and then also having the knowledge. So when you are making, sort of examining your own beliefs, but having some knowledge of where you're coming from. oftentimes it's really sharing experiences, and that was one of the things I felt was really helpful for me, because I had been practicing for a number of years, probably up to 20, when really this recognition of different cultural practices around end of life was really quite apparent. I was not informed, and that wasn't something that we had in-service on or anything like that. So I had to seek that sort of information out myself. I had to get that formal knowledge about different cultural practices, in particular end-of-life practices, so that I could really provide that end-of-life care and provide that culturally sensitive care that I needed to have the skill set when dealing with those different types of cultures. And an example for me is even just teaching to a diverse student population. We've got different age groups, we've got different experiences, we've got different cultures, and whether we like it or not, different cultures have a different respect for education. Some cultures revere it, and you really get that sense, whereas other cultures don't value it the same, and that's okay. That's just that culture. That doesn't mean that the student isn't doing what they need to do. It's just a different culture, and we're all aware of that. But I find particularly challenging is the millennial workforce right now. We have various age groups, and they all learn differently. We had a lecture on that just recently, where they said, how does the new student of today learn? And we listed all these attributes that might not have been as favorable, but it's the truth. They want the snippets of information. They want to know what pages to read. They want to make it quick. They want to make it fun. And who doesn't want to have fun when learning? But I guess it's your definition of fun, because I find this fun, but you may not. And so it's all these different definitions. And so when they push that sliding door across, then they said, and how do you like to learn? Well, we like to read it from the entire book. We like it systematic. We like to have it, do a 3-hour class and have a bit of break. And so they opened this up, and we had this comparison of learners of, my era and the new learners, and how do we actually teach to those new learners? So really important that we recognize the wide student population and how we can appeal to every one of those learners. And not only do we have to appeal to all those learners, but we have to look to see what is your learning style as well. So these are the sorts of things that you need to consider when you are providing care for your patients as well. And it's a lot of self-reflection, but it's also bringing people together and reflecting teacher and student encounters, student and client encounters, thinking about all of that, and really soliciting feedback, looking for a lot of feedback on how am I meeting your needs. As you would ask your clients, am I meeting your needs as well? And so diversity in Canada, as you can see, there's over 200 different identified ethnic origins. There's a number of visible minorities, although I want to say I think that's changing. The percentage of population over 65 years. Again, these are sort of demographics around 2010, because they report them later. We're still waiting for current statistics. But you can see how there is a changing demographics and a changing diversity. Just a little practice question thrown in to see if everybody's paying attention. So which one of the following is the most important input into any health system? And so have a quick peek of those, A, B, C, or D. And if you said A, human resources, you are correct. That is really important. We can have the best hospital building, we get the best supply system. We need human resources to operationalize that. And you'll find with anything that you are engaging, whatever project or whatever, it's all about the human resources and how you are operationalizing that. Okay, so and we sort of alluded to that in a previous PowerPoint about not only do we have a wide, diverse student population, but you're working in diverse environments in the hospital as well. And so it's really acknowledging those differences in the learner or the staff, but I just want to remember that we don't stereotype. we just, but often when somebody is doing something that's quite annoying, you think, oh my gosh, what are they doing that for? And then you're going to go back and you're going to think, because that's the way they learn. That's the way they do things. And so, as you know, you probably don't work with very many veterans, but you care for veterans. And so they don't like to rush things. They're not only the elderly, and it takes longer to process or longer to move, but they don't like to move. They don't like to rush things. They need time to create a relaxed pace. They will be very respectful because that's the way they were encultured into society. It's yes, ma'am, no, sir, please and thank you. They're really, they're very focused on grammar and correct grammar, and they feel a bit more formal. And so that's why you always would identify, you know, Mr. Smith, and they may say, no, please call me John. But you would always identify them by their surnames. The baby boomers that are born between 46 and 64, who are now probably the aging part of the workforce, or what does my colleague call us, the aging professoriate. I might take exception to that. But again, they're quite personable. They may not want to do a lot of the social chit chat. Like, let's just get on to the point. But again, however you create that context, they like to be, you know, have that warmth and that feeling of sincerity. But they don't want to get around. They don't want to do a lot of social chit chat. They do take time to check in, and it would be important for you to find out from them how they're doing. So how is this meeting your needs? They like to have that relationship, and they may recognize that in informal ways. So when you're working, you may be working with a number of baby boomers in your workplace. Then we have the Gen Xers, and again, I just want to remind people that every generation has sort of some negative connotations, you know, and so I don't want you to sort of go to that place. We all have different attributes, and that we want to encourage and embrace all of the differences that we all have. And so our Gen Xers, they want to be efficient, and that they want to be very perceived as being competent. So they don't want to do the relationship thing. They want to be seen as doing the right thing at the right time. They're very competent in their role. They may ask a lot of questions, and so I know that when, as I think I shared with you, my preceptor, I asked a lot of questions, and finally she said, Leslie, you can ask 3 questions. And so I had to make those my best questions that shift. And so I'd have to do a lot of fact finding myself. And then when I no longer could find the answer, then I would go and ask Joy. You want to make sure that you're pretty confident in all your facts and figures. So you want to make sure that the knowledge you're imparting is correct. One of the things that the Gen Xers don't like you hanging over, and although that's sort of in direct conflict or direct opposition to that helicopter parent that sort of hangs over and checks in to make sure everything's going well. So they want to be able to be independent, autonomous, and make decisions on their own. So just acknowledging some of the diversity in the generational diversity that you may experience either as a patient or in the workforce. And I think that that's what the challenge is in the workforce right now, is that we do have 4 different generations. They're all very distinct, and they do things a bit differently, but knowing that it's okay. It is okay. So for the veterans, my 80-year-old mother still goes to work every day. And I do think there's something that she has to retire before I retire. So, but she's still going to work today because she values her job, and her self-worth is gained from her job. However, my daughter, it's all about, I'm not working Christmas. This is, you know, it's about work-life balance. So again, no one is right or wrong, but just to acknowledge that is a difference. Abilities. And so again, looking at diverse populations in terms of developmental, and we, especially nurses, we looked at Benner's novice to expert. We look at the physical, the emotional, and the cognitive. We also, in learning styles, this is one of the things that I keep at the forefront, is acknowledging different learning styles. And so some people like to have PowerPoints, and you know, my belief on PowerPoints is I hope I'm confidential, and I'm taking this down as soon as everybody reviews it. I find PowerPoint's lazy learner, lazy teacher, because for you to really learn is to really immerse yourself in the content. And so it's really important that you engage. So it's easy for me to actually just sit here and talk to these PowerPoints, and you know this is not really my preferred method, but this is extenuating circumstances. But again, with acknowledging different learning styles, some people do need a PowerPoint because they need to read it to get a foundation, then they need to do other things with that knowledge. With my year 2 med surg group, we do a PowerPoint in advance of the class. They come to class. We do about 6 activities that will immerse them in the content. So it might be order how to do a trach care. It might be, here's a case study. What is the nursing interventions? I do a lot of concept maps. So preparing these comprehensive concept maps so that you can see how all these pieces pull together. So we do a lot of that. And then I ask them to reflect on that and do a reflection. And to me, we were assigning reflections, and to me, I was thinking, I'm not doing it because it's just a make-work project, and you know I don't believe in that. However, what I've come to learn is that with you going home and reflecting, and even to review this video at a later date, or by you going home to reflect, and typically it's within 72 hours, but even within the week after the content, if you just purposely and deliberately think, what did I learn in that class? It puts it back into that short-term memory, because when you come to class, you're racing. You quickly take notes. You don't even think about the words you're putting on the page. Then you're gone. And you don't revisit it again until the exam. You memorize it for the exam, and it's gone. I don't want that. I want it to be archived into your short-term memory. By deliberately reflecting on it, it then gets archived into your long-term memory. And when you're writing your synthesis exam or your NCLEX exam, or in practice, you'll have that knowledge retrievable. So one of the learning theorists is David Kolb, and he bases his theory on experiential learning, or we base our work on David Kolb's experiential learning theory, which really aligns with me personally because that's the type of learning I do, and I have to remember that not all students learn that way. But also that with simulation-based education, that's my research interest, that by getting your hands on stuff, it really helps you to learn. So we have divergers who look at things at different perspectives that would rather watch rather than do. And so some people need to have that quick demo, and you'll find next semester when we do our health assessment, I will do a demo of the difficult pieces of assessment. So because that's how you learn, you want to see it done first. So these divergers are the idea generators. They like to do a lot of brainstorming, and they're very strong in the arts. And again, this is all just very stereotypical, but generally. Then there's the assimilators that are very concise, very logical. The ideas and concepts are most important. And they require a very clear explanation rather than the opportunity to come into the lab and do it. They want to have that chapters, they're going to read it and tell me what I'm reading. Then there's the convergers that are the problem solvers. They like those case studies, and they like the technical piece of things as well. And so they want to take this case study and really expand on it, come together and think about what are some other solutions to this. And then there's the accommodators that are the real hands-on. They rely on intuition, and my thoughts on intuition rather than logic. And I'm going to suggest that intuition is based on logic, and they prefer a practical experiential approach. They might have that, they say gut instinct, but it's really not gut instinct. It's really more around that recognizing patterns. And so that's where that accommodator piece, they like the action and goal, the initiatives. And so I have to say, for me, if someone said to me, do you like this new schedule? I would have to say, until I actually work it, I have no idea. It may look really good, but I just have no idea. And so that brings us, we have a lot of diversity in nursing for a variety of reasons. It could be our generational workforce. It could be our rapid immigration. And that reminds me of in the 1980s when we opened up nursing. We were such a shortage of nursing that we really did massive hiring from other countries, particularly the UK. So in I think the 1990s, we had a huge influx of British trained nurses, as well as others. We did a massive recruitment from India as well, I want to say in the mid 2000s, because we didn't have sufficient nurses. And so this really contributes to that diversity in the workforce. So there's gender issues, socioeconomic diversity, religious practices, sexual orientation, family status, language, and other characteristics that really can contribute to you as a person and how that impacts the environment, the work environment. So openness to diversity, it's important to be open and to be receptive to new opportunities. And one of the things I really want to emphasize that to demonstrate culture of humility is that you need to be inclusive. You need to recognize the uniqueness of that individual. And you need to, they need to experience growth. You need to recognize their growth and really to understand that you will grow as a professional. Mutual respect, and I can't emphasize that. It's really important that we are respectful of all of our colleagues and our patients, and to value their opinions. So I believe we begin to identify learning needs by expressing openness to diversity. And inclusiveness is really including everyone in the whole process. So don't do anything that would be considered to marginalize people. And so I'm going to get you to pause at this point, and I'm going to invite you to go to the Public Health Agency of Canada and look at the 12 determinants of health, and just get a sense of how that would impact nursing practice. So you can pause and do that. I'm going to carry on to the next slide. And so we're going to talk about the 12 determinants of health. And I just want to remind you that while you're trying to memorize all this, and I think this is not really a list to memorize, it's not a laundry list, I think it's stuff you recognize every day. But I do want to emphasize with you that these 12 determinants of health, you're going to be exposed to again when you do the interprofessional course. And that I assist the professors to do a simulation in that interprofessional course. And what the student feedback to me is, I learned what the 12 determinants of health are. Like, I've seen the list, but until you experience the simulation, you don't understand. So I'm going to just leave that teaser for you that you need to show up for that simulation. It's really quite phenomenal. And so the 12 determinants of health, they influence the health of populations. They include the income and social status, social support networks, of course, the education and literacy of a population. We know that some countries, they lack public education, and that really severely impacts that culture. Gender, employment and working conditions, social environments and physical environments, health practices, coping skills, healthy child development. That's a really big one. And I'm just going to put a plug. Also, we do have an advanced pediatric course as an elective for those of you who'd like to take an advanced pediatric place. They don't do an actual placement, but they do an advanced pediatric course. Gender and culture. So all of those things are so important in the determinants of health for our society. And they play a really big role in the health of Canadians. Culture is the learned beliefs, values, and norms, and the way that influences thinking, decisions, and actions. They are individual, and they're learned, and they're shared. So I think we've talked about culture. And so in this slide, they sort of summarize culture as being everything about you. And so that the way you live, the way your perspectives, and your communication. And so all of these things are influenced by culture. And I think that it's pretty comprehensive there on that list. And so I just want to remind everyone that even despite all these differences, remember that the CNO Code of Ethics dictates that we provide care regardless of the culture. And so learned beliefs and values and norms and the way of life influences thinking about decisions. A lot of times, and I want to make sure this is very clear, a lot of times culture is rooted in race and ethnicity, but not always. So you can't always assume just because she's from the UK that she likes to have tea and crisps. You know, we just don't have those assumptions. But just remembering that there is some differences and to be aware of those differences. Nursing culture as part of our CNO practice that dictates that nursing practice has basic values that define our culture, and that we, again, all of those therapeutic communication, caring, empathetic, truthful, promoting health and autonomy, and respecting client choices. So here's a dilemma, and it'd be interesting to hear what your perspectives are on this. And so the dilemma is that I'm organizing a and again, I'm destroying this tape after everyone reads it, everybody views it, because this is under the cones of silence. So maybe I'll take it out of my context. So there is and we're going to talk about our culture, and including Aboriginal populations in Canada. And so part of that is that we need to have elders, and next semester we do have a visiting elder coming to one of our classes. So we have the elders an elder to come and explain some of the differences about Aboriginal communities and how they're faring right now. They also will, because we're on Aboriginal land, we always open up our ceremonies to acknowledge that we are on the lands of the Mississaugas, to acknowledge our heritage and being respectful. Now, part of that and so once they do that, what we do as an offering is we give them tobacco. What are your thoughts on that? Is that, knowing that tobacco is such a health risk, is that something we should do? Or do we demonstrate cultural humility and provide them with tobacco? So I'm just going to let you ruminate over that, and I'll be interesting in the new year. We'll have a more fulsome discussion on that. But I just thought, isn't that an interesting thought? So do you violate your own code? Again, I'm not picking on the smokers. Violate your own code, because I think cigarette smoking causes so many deaths. How can I actually just hand them something that's going to cause their demise? Or do I respect their culture and practice culture humility? So I'm going to let you ruminate on that particular case. Moving into transcultural nursing, we're going to talk a little bit about Leininger. And again, we're just going to have these little snippets of these different theorists, and you're going to be fully immersed in these next year. So early in Leininger's career, she recognized the importance of caring in nursing. And I'm sure that there's not anyone who doesn't realize and associate nursing with caring. And so frequent statements of appreciation from the patient of this care that Leininger had provided prompted her to focus care as being central to nursing. And I don't think I'll hear any arguments from the audience that caring is central to nursing. And I have to honestly say, while we give you some formal lectures on how to care, I really believe it comes from within. Own personal opinion. But Leininger experienced what she describes as a cultural shock when she realized the recurrent behavioral patterns of children appeared to have a cultural basis. So when she was providing care for children, she all of a sudden thought, wow, that just sounds like their parent, and did not realize how tightly connected those were. So Leininger identified a lack of cultural and care knowledge as the missing link to nursing's understanding of the many variations. So this is how she began with this new theory of cultural care, diversity, and universality. And so again, I just want to, I'll show the actual framework, but just a way of explaining, and that's what theories do, that's what these frameworks do, is that they're a way of describing, explaining, predicting, and researching, because we might have different concepts. This gives you you're able to compare apples to apples. And so this cultural care theoretical framework is a way of describing, explaining, and predicting nursing similarities and differences. So cultural care, according to Leininger, is that care is the essence of nursing. No arguments from any of us. Caring is essential for well-being, health, growth, survival. Culturally based care is comprehensive and holistic. And again, remember that the care that an RN provides is holistic. We don't just do a vital sign. We don't just do give the pills, the medications. It's holistic care. And so how is this medication going to impact this patient? Cultural care cultural care concepts, meanings, expressions, patterns, processes, and structural forms vary transculturally. So within one culture, you're going to see differences, but also you'll see some universalities or some of the common things that are common within the culture. So the goal is to discover and explain diverse and universal culturally based care factors that really influence health. And so what I like this is, we refer to this as the half moon kind of framework. And it's a bit busy, and not that I really want you to memorize every single word on this framework, but I just want you to just get the overall view of how at the core there's holistic health. And then as you see the cones or the circumferential pieces around that, it's all influenced by all of those things that are around the core. So again, we know that what affects holistic health would be religious and philosophical factors. So maybe they don't believe, or maybe they do believe that different complementary therapies will work, because that's how their mothers did it. That chicken soup's going to work. So again, that religious or philosophical view. And then you can see overarching are the society or a larger worldview. What is really important is that listening with an open mind and learning from your patient is the most important thing, and not to impose your own ideas. Well, that chicken soup won't work. Are you kidding? Who told you that's going to work? So don't impose your own ideas. Really check and recheck to make sure that you heard correctly. So it's all about listening in the practice of that culturally competent care. Transcultural care, the care provided through the assessment by providing respect for clients and incorporating their values and beliefs and practices into the care. And so where can I get you your chicken soup? If that's what you need to make you better, I'm also going to give you this IV antibiotic for that pneumonia, but where can I get the chicken soup? So just really incorporating that culturally sensitive care into your practice. Outcomes of culturally competent care is that you will develop cultural humility, but also you'll understand their approach to maybe pain management, childbearing, things that are there from a cultural perspective. What are stressors? And that you'll be able to provide that individualized holistic care. Culturally competent care refers to complex integration of knowledge, attitudes, and skills that enhance cross-cultural communication. So by becoming culturally competent, I'm going to acknowledge my own culture. I know what I believe in. And so as I move forward to care for my patients, I'm not going to impose my beliefs, but what would you like? And where do I get that chicken soup? So really, it's that incorporating their own belief system into their care. So Developing cultural competence means awareness of one's own cultures, as we said, understanding one's own worldview and that of the other. And I think that is built upon Jean Watson's point that to provide care, you need to know you need to know your patient, and then you come together. And really avoid stereotyping. You know, this is the way they practice this because that's their culture. So again, don't impose your value. And that was something I had to learn as well when I was dealing with this international organization, that while I thought I was doing the right thing, I really had no idea what that culture, how they interpreted knowledge or learning. And so I had to really take a step back and acknowledge my own culture, but also what would learning look like for them, rather than thinking that, oh, this will be perfect. No, what do they need? Showing respect and dignity for every patient, that is just key. And can I just say, it's not even just showing respect and dignity for the patient, it's also for your colleagues as well. So they may have different practices, and to be respectful for that. So if your colleague needs to attend the chapel at a certain hour, let's cover for them so they can get to their prayers or whatever they need to do in the chapel. Accepting the rights of the patient to refuse the care, that's okay. I'm going to tell you that by refusing the antibiotic, it may take you longer to recover. This antibiotic is specific for that pneumonia that you have. I'd be glad to get you more chicken soup, though, whatever. And so being accepted, they can refuse that. With Jehovah's Witness, it's another good example where their common practice is they refuse blood or blood products. And so, but actually, how does that person operationalize it? So when we had, in another ICU I worked at, there was one patient that, you know what, I'm going to take blood because I want to live. He had leukemia, so he wanted to live. So in the ICU, the nurses put him in, fully abiding by his wishes. He made it very clear he wanted to receive blood, but he was afraid of what the family or the church, he did not want to be shunned or ostracized. So we upheld his confidentiality, not us, this unit. They pulled the curtain, they gave him the blood transfusion, finished everything up, got rid of the IV, got rid of the all the evidence as per his request. And remember, it's all confidential. And so we gave him the blood. Nobody was the wiser. That's how he chose to operationalize his religion or to practice his religion. When I've had patients that are Jehovah's Witness that are on the bypass machine, so they have had bypass surgery, we actually stop the heart, so there's no blood, so the blood is actually circulating outside the body. And there was some discussion with the patient, is this okay, because the blood was outside of the body? And his first response was, no, I can't receive it. But then we were able to come to some common ground that the blood's not stopped or pooling, we were putting it through the bypass circuit. And he said, you know what, because the blood is not stopped, the heart it's still being sort of circulated through the body, that was acceptable to him. So we were able to do the bypass surgery, but he would not accept blood that had been, so we used to do what we call auto transfusion. So we take, and you probably see on your Thoraclex machines, your chest tube reservoirs, we had a device that we would actually, in the first several hours after surgery, they bled so much, we'd actually give that back to them at one time. And so the patient felt that because the blood had stopped and was sitting there for like an hour or two, that would not be acceptable. But on the bypass machine, that was acceptable. So there's many variations. We have to show respect and dignity for every patient. They have to have knowledge to make informed decisions, and then accept what their wishes are. And we may need to really think outside the box, as we did with this patient having bypass surgery. 5 key values for cultural competence: inclusivity, respect, valuing differences, equity, and commitment. So that's from the RNAO best practice guidelines on providing culturally diverse care. The goal is to provide support to nurses working across cultures, and it really links quite nicely to the therapeutic nurse-client relationship best practice or the guidelines. I think, again, this is not anything that's you don't know. Acquiring cultural knowledge, being familiar with common culture you work with. And so if you're working in a particular geographic location, there's different pockets in our city that have more of a, and that's the beauty of our city, is that we do have a very diverse multicultural city, and there's pockets that have settled. We have, what do they call it, Little Italy. We have Polish areas of our town. We have predominantly South Asian or Chinese populations. We have Indian or different populations out in different pockets. So if that's what predominantly the culture that you'll be dealing with, it's really important that you have a good understanding of the broad tenets of that population. We have our all, you know, what is it, 50 different cultures in Toronto with large pockets, and we have to be aware. So another example was when we had a patient die, and I believe it was around Christmas time, because we were on skeletal services. A patient of Jewish faith died, and one of the beliefs is that they have to be buried, and other religions, buried by sundown. And so but the family couldn't get there because of they couldn't travel through the holidays. And so we actually had to pack that patient on ice to keep them cold till the family arrived. And that's what we did. Another example is that a patient, and I want to say he was of Punjabi descent. He died in our CBICU. Of course, I was the charge nurse. And in their religion, their practice is, and again, this is the way these people practice it, is that the individual, the deceased, had to be taken back to their faith place, the where they practice their faith, the building, the church. They had to be taken back there. They had to be prepared for burial in accordance to their religion. So, and that meant that they had to be bathed, and certain people had the privilege of bathing them. And to me, it sounded so wonderful, just really quite respectful. Where I was challenged is that they sent in some people, and of course, again, I had to keep an open mind, but they sent in these people, about 5 men, to come and pick up the deceased from my unit. There was no funeral service provider, a mortician or anything like that. They just sent in these people, and one was a very young boy. So I was quite alarmed that this young fellow was a part of this. But again, my own values. This young person is being enculturated into their faith, and that would be a role he'll have to perform. But what better way with somebody he didn't really know. But what happened is they did not know how to get this patient onto their very narrow stretcher. So finally, I had to get my transfer board. I was able to do it myself. I said, everybody stand back, put the brakes on. I'm putting the brakes on. I was able to bring the patient over, put them on the narrow stretcher. And I had actually had all the documentation to say that they were able to transport this patient back to their church. But I felt a little bit nervous because I'd never done this before. I let my supervisor know that I was actually discharging a deceased patient, transferring right back to the church. There was no mortician coming. And so I thought, well, I'm just going to go down to the back door just to make sure everything goes smoothly, because I wasn't confident they had done this before. Anyways, I followed them down at Sunnybrook to the back entrance, where it was where the morgue was, where the mortician would actually come into that whatever B wing or whatever, and also the flowers. So I followed them out, and they were actually putting the patient into the back of just a regular minivan. And I felt a little bit nervous, but I had to really look at my own values and recognize that this is the way they practice their faith. And everything was absolutely fine. But it was a little different, and I had to acknowledge the differences. But when I reflected on it, I was really quite taken by the respect they were treating the dead. Now, my colleague, who is in some war-torn areas now in Syria, he said his biggest, they have such a deep respect for people that have passed away or people have died, especially. So he was just at a area, now this is going back about 6 months ago, they bombed the hospital, and a lot of the patients' families were, and the staff actually were killed, and they were lying on the front steps. And so he had a hard time telling these people, those people are dead, leave them. We need to get on to the people that are alive so we can triage and save them. But he had a hardest time because that was their religion, their faith, to actually protect them and respect the deceased with such tenderness that he had a hard time really pulling them away to get to the people that were still alive. So again, being very open to these different cultural practices, using a lot of self-reflection, but always it's about patient choice and how they choose to enact their religion. I think we've talked about some really good examples. These are just some more examples of different cultural practices. I don't think I need to go through them with you folks. Communication, again, is another big area of cultural diversity. So speaking and writing the language used by the clients, and a lot of times there's quite a diverse language, and however, and for me being Vice President of International Affairs with my community, with my simulation group, we've actually translated several of our important documents into various languages. However, and so what I've done a lot of research into, how does that occur? And so when you're actually translating, because there may not be words in these different languages, so you're going to get local people, because it needs to be adapted to that local context. You get people to translate it into that language, then you get a group of experts that will translate it back. And one of the challenges is that, as I said, there's no words for teacher. And so what word would they use instead? Does it have the essence? It doesn't need to be verbatim, and so a lot of our pamphlets that we hand out, it may not be verbatim, but it gives the essence of what we're trying to communicate within that local context. Using alternative methods for communicating with non-English speaking clients when there's no interpreter available. Just want to highlight that there's a lot of online services for interpretation, and I would recommend we use those. We've talked about how interpretation by family can sometimes be problematic, because they are going to communicate what they want to communicate to their loved one. They don't want to say they've got cancer, because then they would not, that would just, they'd give up and they wouldn't. So again, using those services and being aware of some of those cultural aspects. And so some of those things for the cultural pieces of communication, some religions, it's important to have an eye contact. Some religions, it's very important not to have eye contact. Some religions, you can shake hands or touch someone. Some religions you can't. So being really astute and having insight into the populations that you serve, but also the people that you work with. Hygiene. Again, lots of different practices around hygiene and skin care, hair care for various ethnic backgrounds. So don't assume, don't impose your own, well, they didn't have a shower today. Again, being very, very mindful. And some of the different activities of daily living, again, I just bring to you, some people for different religions or different cultures using chopsticks versus a fork. And how do you rehabilitate someone who's had a stroke? Or some of the Amish folks, and especially we have a large Amish, and they don't call them Amish, I think they call them Doukhobors in Alberta. But similar philosophy. They don't use electricity. They use buttons and pins. They make all their own clothes. And so if someone has paralysis, how do you actually get them to do up all those buttons? And then some of our clients use different methods of oral hygiene. So I just put that out there as well. Religion, so birth and end of life are really big pieces that you have to be familiar with. And so really around some of our patients have really defined practices for birth. And so one of the things is that if a baby is being stillborn, they might do an emergency baptism, because of all of the faith, their beliefs around getting to heaven. So the baby needs to be baptized, or the sacrament of the sick, for Roman Catholic belief. They have this ritual circumcision in the Jewish faith. And again, Uh, they do this. This is a ceremonial procedure, and so it's not a surgical procedure. So being really aware and not imposing your own beliefs. And again, I just want to emphasize that we are all different, that we have become not a melting pot, but a beautiful mosaic. And we're very fortunate in Toronto to experience the best of all these different cultures. We are so enriched by it, and we're well recognized around the world because of it. I do have to talk a little bit about the Truth and Reconciliation Commission. Now, let me just want to, oops, let me just pull up my piece here. I just want to play a short video clip for us. The Truth and Reconciliation Commission is come out just in the last, I want to say, 1.5 years. So the Truth and Reconciliation Truth and Reconciliation process is about the Aboriginal children that were taken from their families and put into residential care or institutionalized. And I can hardly say it without crying. I could not imagine taking, and there's these pictures of these adorable little children that have been taken, you know, what is 5 years old and older, taken from their families, their mothers, and taken and put into residential school. They endured very harsh conditions, a lot of them, and there was many that actually died. And I have to say that the church, so that for over 100 years, Aboriginal children were placed in these residential schools with the belief that they were going to be socialized, or there was always that Wild West kind of thought. And so that they thought, well, we'll bring them into these residential schools, we'll show them how to behave, we'll eliminate that Aboriginal culture. So there's no speaking any of their native tongue, there's no other Aboriginal practices such as their ceremonial dance, their ceremonial dress. They did a lot of living from the land. They really believed in the preservation of the land, so they thought, no, we're going to get rid of that. And so they brought them all together. And so these were government funded. The government has a huge responsibility, but it was administered by the church, believing that that was the best possible source for all these children. And in fact, these children were subject to sexual abuse, harsh conditions, poor food. It just breaks my heart. So now we're at a point where we have to have a collective effort to revitalize the relationship between Aboriginal peoples and the Canadian society. So as a result, we are acknowledging, and I think that Prime Minister last year had a public forum and acknowledged the damage to these children. And if you listen to the CBC, they've got some great little podcasts about how people felt during this. They had no identity, they couldn't speak the language, they felt they were stupid. It just goes on. I can't even listen to them because it just breaks my heart. Who could do this to children? And so, but I just want to play a quick video clip of this.
Professor, I didn't hear the video.
Thank you. Oh, Laura, just go ahead.
There was no sound on the video. I couldn't hear it.
Okay, so what I'll do is I'll send you the link. I'll add the link so that you can click on it yourself.
Okay, thank you.
But it's very good. So, truth and reconciliation video. I tried to upload it and it wouldn't load for me. So this is the link. But I'll post it with this video. So thank you for letting me know. And I really encourage you to listen to it. It's very compelling. And the language that she uses, I find it almost offensive. However, that is the way it was. And so just that we are aware of the damage done to our Aboriginal population. These were children that were raised in these sorts of environments, very harsh, uncaring environments. And our speaker said that that's how they're treating their children. So that may impact you when you are working with these folks or when you're actually taking care of them. So just as when we're moving forward, we're really helping to remind people about the sacrifices of our forefathers. So I just wanted to highlight that, and just that there is millennium goals that are developed by our government and by WHO, the World Health Organization. And so which one of the following is a millennial development goal that relates to health as agreed by the United Nations? And so C is reduction in child mortality. We're lucky here in Canada that we don't have as high rates, but around the world they're quite high. And so this is really the goal is in reduction of child mortality and better antepartum and postpartum care. One of my colleagues, who's a simulation expert, she actually took a pair of scrub pants, just a regular old pair of your scrubs. She sewed a bit of a pocket inside where she puts a plastic bag which is filled with red food coloring and water, and she opened up the seam of the crotch of these scrubs, and so she does simulations with people all around the world in these very poor villages. They do, because a lot of times there's no physician or healthcare, it's a midwife, and so helping to prevent postpartum hemorrhage, and so really helping people to know what to do, and that has made an impact. As simple as a pair of scrub pants has made such a difference in infant mortality. So that concludes the presentation today on cultural humility. Just really highlighting that we need to provide culturally sensitive care to all of our patients, and we need to be we need to work in diverse environments. So really examine your own values, your own culture, and being aware of that, and really providing that non-judgmental care. So yeah, for me, I was really examining my own thoughts about, again, even just receiving blood, that was knowing that was that person's right to refuse blood transfusions. And we know that blood transfusions can do all kinds of bad things as well as good things. But I had to really look inward to say that was not my belief, that is the patient's belief, and I need to uphold their right to autonomy. So those are the sorts of things you really need to examine. We are no longer that blank slate that we always professed, that we always thought we taught. You're blank, you just go in. No, we're not. We have our own culture and beliefs that is shaped by our family, our society, our experiences, our culture, our geographic location. And so we do have that, but we have to acknowledge that. And then we have to provide that culturally sensitive care and really practice that cultural humility, or lowering ourselves to really not think that we're the only way things are done. We have to really look at those multiple perspectives. So thank you so much for joining me on this Zoom platform. I'm hoping that you found that it worked well for you, and that you did not have to travel to campus, and that you can enjoy the rest of your day. And I just want to say that I'm so appreciative of being with you this semester. I look forward to next semester when we're going to be together for the integrated pharmacology and health assessment. You're going to find that's a great course. So I look forward to working with you once again. And I'm going to do another Zoom from my office that will help you in your studying and preparing for the final exam on January 30th. I am going to wish you all a very happy holiday. Please get some rest. Remember, one of the care processes that you need to do self-care. So I'm going to invite you to take some days off and really just relax. You've had a grueling semester. You're through it, and I will see you in the new semester. I'm going to, so please feel free to go, and I'm going to go back to slides 1 to 7 for those of you who may missed it when I had started the recording. Thanks, everyone. Bye now. Merry Christmas, happy holidays. And so I'm going to start again with our first bit of PowerPoint. I'm not sure that it recorded, and so I'm going to continue with that piece. And so I would like to welcome you to Diversity and Cultural Competence. As you are aware, it is so key to nursing practice. And so really that we have to, especially with our culture, we have such a diverse culture, and we have to practice that culturally sensitive care. Our learning outcomes for this particular session will be to define diversity and explore Madeline Leininger's cultural care theory, explore diversity in the context of current Canadian nursing practice, understand individual client coworker needs in relation to diversity, define cultural competence and review C&O competencies related to RN practice, and review the RNAL DPGs. And so I just want to highlight that, where are we at? Let me see if I can just pull this down a bit. So where are we at? And as you can see, this is what we've covered this semester. And as you come into the program as an RPN, highly motivated to that lifelong learning journey, that as you can see that's where you are in that sort of that transition RPN to BSCN, and then moving out at the other end as the BSCN RN practice. And we know that is a bit of a, there is a bit of a challenge there. So you come in to the program, and we're going to change your perspectives. We change your thinking, because RN practice is thinking. We change the way that you may do things. And so you might have been able to do things very quickly and not, and really not, and been very task oriented. Now we're going to move that to being very thinking oriented. And now that you know the right way to do things, and I'm going to, I've challenged you all the way along, that once you learn this, there's no going back. And that's hard. When you're working, the role you were hired for was to do one thing, and now we're adding that a little bit higher level of thinking and processing. and actually performing. And so it's a bit difficult, we know that, and also perhaps you don't have the support of your colleagues. Perhaps there's colleagues thinking, wow, she's back to school, she thinks she knows it all. At least that, and that's sort of the attitude I got as well when I went back to school. Because people don't want other people to look different from what they are. And so really there's some challenges with that. And then you're sort of thinking, well, this is the way I've done it, and I've always done it at work. Why do I have to be deliberately following a nursing theory? This is the way I've done it. And then as you move into the middle year, it is that, oh my gosh, I just have to get it done. I don't care what they tell me, just let me get it done. And then as you move out of the program, it's going to be that aha moment, and really, how have you changed as a person? And so we talk about lifelong learning. We talk about role development. So as you are thinking about the RN role, you're becoming more expert in your RPN role. It's the adaptation to change. You know that as you move through, and Flexner has that really good model of change, and how do you think differently? How does it affect you as a person? And we also talked about transitions through history, and how does that change as we had over the years. And I think back when we talked about Florence Nightingale and how she was the first statistician, and even very forward thinking for her time, and how she really believed that there was other elements to it, to healing, and that was ventilation and warmth and all of those things, and cleanliness. So there's all those things throughout history about transitions. Communication, we talked about how important it is to communicate as a professional within the interprofessional team, therapeutic nurse-client communication, conflict resolution as well. We also have talked about, why do you need to use critical thinking? And some of those higher levels that the CNO will that expects from the RN. And we talked about frameworks to guide your critical thinking. We've talked about client-centered care, and what does that look like? How do you provide client-centered care, and how do you provide client-centered care to the patient and the family? Managing conflict. We've also talked about the ethical legal issues that are coming forward. We talked about the NCLEX, and I just wanted to again identify the NCLEX exam is the entry to practice exam that you will be writing, and it is a little different than what we have in the past, probably a little different than what you've written from your PN program. And so that NCLEX exam is a computer enhanced exam, a computer activated technology. And so what that means is that you may get 70 questions. Those 70 questions may mean that you know everything. So this technology is 100% guaranteed you know it. And so they'll stop you at 70 questions. Or you may get 70 questions and think, oh, this person doesn't really know it and has missed more of the questions, so there's no point in giving you any more. And so they'll stop you at 70 questions. Or you may know some of the questions, and they're not just sure that you know the concept 100%. So they'll keep throwing questions, say, let's say, GI nursing. You don't know as much about GI, and so they'll keep giving you GI questions, and they'll give you perhaps up to 250 questions to complete, to be certain that you know it. And the NCLEX has alternate format, and that's what we're preparing you for, and that's why you'll find different formats. So one of the things they do is they actually will have you put a headset on, and you'll hear breath sounds. So you'll hear crackles or wheezes, and they'll say, what do you hear? And if you hear crackles, then they'll say, what is the intervention you're going to ask from the physician? Are you going to ask for Lasix, Ventolin, steroids? You know, what is the intervention, so that you'll actually have to identify that. We don't do that as much in the program, but we do have alternative format questions. So all the answers are going to be potentially correct, but what is the best answer in that context? So they'll ask you those sorts of case-based questions. And so they'll ask you questions. They could be a question that you have to, an answer you have to order. So what are the steps of trach care? And you'll have to order that, or they might have matching questions. They have all these different formats to be sure that you know the content. And so that at the NCLEX, and I just heard yesterday that they will be starting, the CNO is looking at approving nursing programs, and it will be part of it will be based on the NCLEX results, very much the American model. And you do know that we were not part of the process to integrate the NCLEX. We did not want that because we don't teach an exam. We teach you to provide excellent quality nursing care in our Canadian healthcare system. So we have you prepared for that. So the NCLEX we prepare you for, that's why you'll find some questions that are a little bit different on the exam because of that. And I do know last year somebody said to one of our meetings, yes, they had this alternate format on the exam, and all of my colleagues said, oh, isn't that great? That was smart thinking. Although the student didn't share the same perspective. So again, we're preparing you for the entry to practice exam. And I just wanted to start with for a moment about Watson and caring, and however you choose to center yourself. And so let's just take a moment here and take some deep breaths. Close your eyes and take some deep breaths in and out. And at this busy time of year, just blow out all that stress. Take a nice deep breath in and out. Let your shoulders drop. Let's take one more final deep cleansing breath and blow it out and really exhale and be present in the moment. And so we're going to talk a bit about Jean Watson's caring. And I just want to remind you that if you were asked by an accreditor, let's say, what is the philosophy of your program? It is the caring philosophy. And so you're graduating from a program that's based on the caring curriculum. And that challenges us as faculty that we need to model that behavior to our students, because you are as we model our caring to you, you will model that behavior to your patients as well. And so caring begins with being present, open to compassion, mercy, gentleness, loving kindness, knowing self before one can offer compassionate care to others. So really thinking about all of those important pieces. Caritas, Jean Watson, of course, you know about the Caritas processes that she and her team have developed in the Caring Science Institute. Caritas comes from the Greek word that means to cherish or to appreciate or to give special attention to. And if not loving attention. And I have to say, several of my colleagues have attended the Jean Watson Caring Institute, both abroad and locally, and they've come back different people. And I couldn't say, well, they do this, that, they do that. It is just that, the loving kindness. It is just that loving kindness. So the Caritas processes, as you can see, Jean Watson has developed this with her group, and so really important pieces to our practice. The reason why I'm bringing this up is that in year 4, and I'm hoping even earlier, especially for when you go to clinical, that the form that we need to complete now will have a place that says, how did you integrate theory, or how did you exemplify the Caritas processes? Because I find that unless you deliberately think about it, you're just doing tasks. And we want to get away from doing tasks and more about the thinking and caring piece. So these Caritas processes will be practicing loving kindness towards self and others, being authentically present, cultivating one's own spiritual practices, and deepening self-awareness. It's developing and sustaining a helping, trusting, authentic, caring relationship. It's really creating that healing environment at all levels, and that might mean a warm blanket. It might be moving all the clutter. It might bringing your expertise. It might be bringing your art to nursing. And as Jean Watson says, caring is knowing yourself and the client, being with the client, bridging the gap between the nurse and the client. So really knowing yourself, knowing your patient, and then how do you bridge that gap so that both of you can come together? And so to care for someone, I must know who I am. To care for others, to care for someone, I must know who the other is. To care for someone, I must be able to bridge the gap between myself and the other. And so I believe that teaching is a form of caring, and as a part of our program mission, we are to enhance the lives of others using a process of inquiry that enables, facilitates, and empowers our students. In order to do this, we must acknowledge the diversity of our students within our classrooms and within our practice settings. And so I just wanted to highlight that this is a cultural competency staircase model that has come from the Harrington text. And so as you can see at the lowest level, the nurse really fails to recognize the importance of culture. Just going along, doing the tasks, getting them all done, not even thinking about who the person is in bed is, just get the dressing done, get the catheter done, get the bath done. But as you grow as a professional, it's growing that awareness of there's a different culture, but I know my own culture, and I know that there's other cultures, but being more limited in my own self-awareness of my culture. And so step 3 is when you acquire that knowledge of 2 different cultures. So I know that my culture is a little bit different from your culture, and I know how that works. So it's that acquired knowledge that really, where the nurses develop that knowledge of the 2 different cultures, or it could even be more cultures, but really recognizing that that is a person in that bed of a different culture with different practices, and how do I interact with that person? Expanding the network. So the nurse has strong cultural awarenesses. Well, I know that that in different religions that they go to their church or their faith center on Sundays. So really developing that expanding strong cultural awareness. It's applying expertise so that nurse is highly aware of their own culture and of the others, and perhaps some other cultures, and start to anticipate, well, if this person goes to church on Sunday, maybe I shouldn't book them into the outpatient clinic on that day, or however that's going to unfold. And then really, when you become very culturally competent, that you are actually at the problem-solving level, that you are, how can we help this patient integrate their own values? How can I advocate for that patient, etc. And so I think we've got caught up to where I was recording, but really just to be aware that there is differences, but to treat everyone in a holistic fashion. So I'm going to stop the recording here, and again, I want to thank everyone for joining us via virtual, live, or streaming, or recorded lecture later. And if there's any questions, please don't hesitate to forward those to me. Thanks so much, everyone. Have a wonderful holiday.